Good evening and welcome. I am Digveer Jayas, Vice President Research and International at the University of Manitoba. I would like to begin by acknowledging that the University of Manitoba is on the original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Welcome to this evening's topic for discussion, Meet the Munchies, Cannabis Research in Manitoba. Tonight's panel is made up of University of Manitoba physicians and scientists with diverse expertise in the use of cannabis for medical purposes. They will provide a snapshot on current medical cannabis research happening in Manitoba and discuss barriers to the use of cannabis for medical purposes. Our moderator this evening is Dr. Karen Ethans, Associate Professor in the Department of Internal Medicine, Max Rady College of Medicine, Rady Faculty of Health Sciences. She is a physical medicine and rehabilitation specialist with a specialty in spinal cord injury medicine. Dr. Ethans is active in teaching and research, as well as the inpatient and outpatient clinical care of people with a spinal cord injury, and commonly known as SCI, and with people with spasticity from many causes such as stroke, MS, and cerebral palsy. Her particular interests are research and clinical management of spasticity, neuropathic pain, and neurogenic bladder. She also runs a baclofen pump program. Her practice is based out of Rehabilitation Hospital at the Health Sciences Center, where she has been for over 21 years, as well as doing outreach clinics at many personal care homes in Winnipeg and to some remote northern communities. She has been treating people with medical cannabinoids, including cannabis, for their neuropathic pain and spasticity for over 21 years, and has published research papers in this area as well. Dr. Ethans will introduce our panel for tonight. I'm certain you will keep them busy with many questions. They will be happy to share their knowledge. Miigwech, thank you, merci.
All right. Well, thank you, Dr. Jayas. I'm really pleased to be moderating tonight's discussion. It's near and dear to my heart. Medical cannabinoids for neuropathic pain and spasticity have been an important part of my practice, both research and clinical practice for over 20 years, as Dr. Jayas said. So a quick overview of how we're going to proceed tonight with our Café Scientifique. First, I'll introduce the panel. And then each of the panelists will speak briefly on their perspective based on their expertise on tonight's topic for discussion of medical cannabis research in Manitoba. Then after that, I'll open things up for discussion and questions. So the questions can be posed on Slido. So you can see there the going across your screen, the website for Slido, and the Café 06 is the password or whatever once you're on there. There's a link on the YouTube description you're watching and also on the screen throughout the discussion. So you don't need to download any software to use this. You just need to put it in an internet browser and use that discussion code, the Café 06. Okay, so I'll be moderating questions from Slido as well as interactions with our panelists this evening. So this brings me to tonight's expert panel. So we have Drs. Linda Belgreaves, Dr. Paul Danek, and Dr. Lauren Kelly. So Dr. Linda Balgreaves is an associate professor in the College of Nursing, Rady Faculty of Health Sciences. Previously, she held academic positions at University of Toronto and UBC, and her research program has focused on the use of complementary therapies by individuals living with cancer, supporting informed treatment decisions. She also engages in health policy and access research related to medical and non-medical cannabis. Currently, Linda is Deputy Director of the Canadian Consortium for the Investigation of Cannabinoids and the immediate past president of the Society for Integrative Oncology. The next panelist I'll introduce is Dr. Paul Danek. He's a medical oncologist and a palliative medicine consultant working with Cancer Care Manitoba. He's an assistant professor at the Max Rady College of Medicine, and he's involved actively in education of medical professionals and has an ongoing research interest in oncology, palliative care medicine, and cannabinoids. He has authored or co-authored several research papers and textbook chapters in these areas and continues to work with others having similar interests. He's taught many healthcare professionals locally and nationally and even internationally regarding cannabinoids, and has presented at numerous local, national, and international conferences. I've personally learned a lot from Dr. Danek through the years through our collaborations. Dr. Lauren Kelly is an assistant professor in the departments of pediatrics and child health and pharmacology and therapeutics, as well as an adjunct professor in the Department of Community Health Sciences at Max Rady College of Medicine. She's a clinical trialist at the George and Fahey Center for Healthcare Innovation and Clinical Trials Director for Research Support Unit at the Children's Hospital Research Institute. Dr. Kelly holds a prestigious Sick Kids Early Career Investigative Award and a CIHR Cannabis Team Grant to study the tolerability of cannabis products in children with chronic pain and cancer. Dr. Kelly is an expert member of the Health Products Containing Cannabis Scientific Advisory Committee at Health Canada and is a member of the Board of Directors of the Canadian Consortium for the Investigation of Cannabinoids. She's a scientific director of Canadian Childhood Cannabinoid clinical trials, and is a pan-Canadian. This is a pan-Canadian research platform that studies the safety of cannabis products for use for medical purposes in children, the pediatric population. Her team is passionate about evidence and partners with patients, parents, doctors, nurses, pharmacists, and policymakers to design and conduct a variety of clinical research studies. So thank you for all of you for joining us. And first I'd like to call on Dr. Balgreaves to share her thoughts. Okay, yeah.
Got it. Hi, everyone. Thanks for joining us. I'm really looking forward to our discussion tonight. And thanks, Karen, for the introduction. I'm a person that's been doing cannabis research since about 2007. A lot of it has been focused on health policy and the impact on Canadians attempting to access cannabis. So that's where I'm going to be focusing my presentation today. So just to start off, I just wanted to briefly talk about cannabis legalization in Canada. It's been a long journey, over 20 years. We were one of the first countries to legalize medical cannabis all the way back in 2001. And over the last 20 years, we've seen different iterations of that medical cannabis program. A lot of it has been through court injunctions, really pushing the Canadian government to ensure that people were able to access cannabis that would help them with their health conditions and in such a way that wouldn't impinge upon their freedoms, i.e. Criminalization, incarceration, etc. And in 2018, we made the dramatic leap towards legalizing non-medical cannabis along with medical cannabis. And so I'm going to talk a little bit about what we got right in that process and perhaps where we could have done things a little bit better. So what did we get right? Number one is we had an extensive consultation process that engaged innumerable stakeholders from across this country, from all different communities, different perspectives being represented. And I was fortunate to be part of that process. And they really tried to gain all the different perspectives around what could be the potential harms of legalization, but what could also be the possible benefits. And one of the things that they were really focused on is acknowledging the harms of criminalization of non-medical cannabis, and particularly that BIPOC communities bore the brunt of those harms. And so legalization of cannabis was seen as a way of addressing that. What was also significant and different from other jurisdictions around the world that have legalized non-medical cannabis is that there was an incredible focus on the public health implications, and that an actual public health framework was developed surrounding the legalization of cannabis to limit any harms that could be associated with that. In particular, a focus on ensuring that the illicit, illegal supply would be restricted, and that high-risk groups such as youth, children would have limited access to cannabis. Another thing that I feel that we got right is that we set federally the legal age of using non-medical cannabis at 18 years. And that's been a controversial decision. However, if you look at the recent statistics of which groups are most likely to be using cannabis, one of the highest age groups are those 15 to 24. And so by having this lower age group, we're ensuring that our young adults are having access to a safe supply of non-medical cannabis, as well as hopefully getting exposure to some of the public education campaigns that have surrounded it. The other thing that we've done is ensure that there are strict regulations around advertising so that it wouldn't appeal to young people, that they would be produced in packaging that would be safe and ensure that children could not be harmed from it. And really trying to combat some of the problems that we've seen around things like tobacco advertising and the populations that have been targeted. And so this might look very familiar to many of you. We have that symbol of THC. However, I do think they pulled this inspiration of this symbol perhaps from other things that are very Canadian. And this is a shout out to my colleague David Hammond that noticed this. However, it does fly in the face of other advertising of other substances in our society, including alcohol. And this is a typical cooler at your local beer store. The other thing I think they did right is that they have federal regulation of our cannabis supply. And as a consequence, we have been able to identify where there's problematic supply issues, such as contamination by pesticides, molds, or illegal products actually ending up into our legal supply. And so I think that's been very useful. We also waited around the edibles for at least a year before we legalized them, because this is a problematic substance for youth. And so we wanted to make sure that we got it right. The other thing we did is that we kept the medical cannabis system separate from the recreational, and we didn't combine them. They are in our regulations, but they're still seen as distinct programs. But what we got wrong, I feel, is that we actually have a real patchwork quilt of how cannabis regulations fall out in each of our provinces and territories. Things like minimum ages are different, home growing regulations are different, even retail sales and distribution of stores. And so there's been some inequities across this country. The other big issue, and if you talk to patient advocacy groups, has been the taxation of medical cannabis. A federal excise tax was $1 a gram applied to all cannabis products, including those that were medical products. And so we've seen advocacy groups step forward and say that this has been problematic. And as a consequence of this taxation issue, we have still seen the legal supply being more expensive than the illegal supply. And that's something that we'll need to work through so that we push more people towards that legal, hopefully safer market. And it has been a bit of a wild west. Unfortunately, this industry has not been, from my perspective, well regulated. We have had the engagement of both alcohol and tobacco companies within it, which has really created some barriers to us doing research and collaborating with these industries. And the other thing I've also seen is that cannabis in many jurisdictions has been equated after legalization with tobacco as well as alcohol, which has some real issues for individuals that are using it for medical purposes when they're getting policies applied to them that are treating it like a substance that's being used for recreational purposes. And I'm thinking about things like policies around cannabis use at work, at school, public use of cannabis, etc. And very lastly, I do feel that there's been some negative implications around legalizing non-medical cannabis related to how we conduct research. And I know that our panel can talk to that more, especially those of them that are engaged with clinical trials. But we've had some issues in terms of, one, getting funding for medical cannabis research, where a lot of the emphasis has been on the impact of legalizing non-medical cannabis. The other issue that's arises is getting access to the supply in a way that Health Canada is comfortable with and doesn't necessarily fall under the rubric of drug development or drug trials. And just to close, currently I'm engaged in several studies. One is the CAVED study, which is focusing on cannabis vaping among youth and young adults in Manitoba. Email us if you're interested in that. We're also working with Riverview Health Centre to understand the use, attitudes, and knowledge around medical and non-medical cannabis in long-term care and personal care settings. And our last study, the CABIN study, is looking at our nursing students and their engagement and knowledge around cannabis. So thanks for the opportunity. Look forward to your questions.
All right, so next I'd like to call on Dr. Paul Danek to share some of his thoughts on the cannabis. Sorry, you're muted, Paul.
Just like Linda, right?
There we go.
I'm not going to use slides tonight. I am going to talk a little bit more about clinical work. The work that I do involves cancer patients as well as patients in the palliative stage of their disease. I see these patients within the clinics, outpatient clinics at Cancer Care Manitoba, and we worked with them to determine what is the best choice for symptoms related to cancer and to end-of-life care. The use of cannabis has become part of our armamentarium. We've been using it for these patients for more than 20 years. The legalization, as Dr. Balneves has shown, has been very helpful for us. It's made it easier for patients who have had to deal with a little stigma of having this or having cancer, even be further stigmatized when they find that there's cannabis products that may make a difference to their symptoms. And I'm not saying that we should forego all other medications, but rather this is a drug that can be additive to other medications that we already have in our armamentarium. But I think that it has become very helpful for patients. Some examples that we've seen through both clinical practice as well as some of the research that we've done. Patients are looking for an ability to control pain, control nausea, control other symptoms, but they also are looking for something that may help them to reduce their need or their use of drugs such as opioids, benzodiazepines, etc. And we've seen that through use of these medications or additive use of them to a protocol, we've been able to reduce their use of these medications. And in doing so, we also have reduced their side effects from these medications. We've increased their quality of life, and we've increased their ability to do things, especially if they're in that palliative stage of their disease. They would like to spend more time, more awake time, more alive time with their loved ones. In terms of other research, we are trying to initiate something called CAFCARS. CAFCARS is a study looking at the use of cannabis for cancer-related symptoms. This is a study that has been started at the BC Cancer Agency by Dr. Pippa Hawley. It is hopefully going to be a multi-site study, and we are waiting final approval through the university and the other ethics departments here. We hope to have this opened up by the fall. And that's all I'm going to say for now. I'm very happy to take any questions that people have, and I thank you very much for your attention.
Thanks, Paul. So next, we're going to have Lauren come on. And so Dr. Lauren Kelly, can you give us a few words of your wisdom? I know there's a lot, but
sure.
Wisdom there.
Thank you, Karen, and thanks for the introduction and the opportunity to share a little bit about some of our research that we have ongoing, which focuses on pediatric use. And every few weeks and months, we see these stories that come across the news about cannabis really helping kids who have complex medical conditions, often children who have failed multiple other therapies, helping them to thrive. And what this has led to is a lot of advocacy behind the use of medical cannabis in pediatrics. Oh, sorry, I think my slides might be on a timer there. And this has created online communities of parents who are recommending products to each other, who are recommending dosing strategies. And the truth is that really when it comes to high quality, all puns intended, research, with the exception of drug-resistant epilepsy, there really is almost no high quality studies that show that cannabis can be used safely and effectively in children with complex health conditions. So the challenge becomes that clinicians, nurse practitioners, and physicians are asked very frequently about the use of cannabis for their complex medical conditions. A recent study in 2017, so we're talking even before recreational legalization, identified that 50% of pediatricians have at least one patient who is using cannabis for a health purpose, and 22% are managing 5 patients or more. So this is really something that we need to develop better evidence for. And in this study, pediatricians were asked, do you think that there is an appropriate reason where we should be authorizing medical cannabis for children? So this is not a small study. It is. I should report that this is of the pediatricians who were supportive of medical cannabis in children, which is about 50%. So the other 50% did not think that any condition warranted cannabis authorization. So that's why you see quite high numbers here. So for those who did believe that there was a reason to use medical cannabis in children, you can see the indications here. So unsurprisingly, like Paul mentioned, the use of cannabis in end-of-life care and palliative care is well supported, as well as in epilepsy and chronic pain and spasticity, along with the work that Dr. Ethans does in adults. For acute pain, anxiety, and attention deficit hyperactivity disorder, a little bit less support behind those indications. So the challenge becomes with a substance like cannabis that is illegal for children under the age of 18. There's a lot of stigma behind it. We are learning more and more about some of the potential long-term effects on neurodevelopment. There's a lot of challenges for how we conceptualize studies. So how do we do rigorous studies when we don't have the same kinds of controls that we would for a drug study? So I'm a drug trialist. Most of my work has been in clinical trials of pharmaceutical products. And when moving to cannabis, this is a very different ballgame. We're talking about every school has a different policy for how children can administer medical cannabis at school. And sometimes that they may not be able to. And how youth perceive cannabis is different. And, your control group, you can access cannabis products without a prescription. So how do you know that your control group is really not having access to cannabis? So there's lots of unique questions, and there's lots of players in this game. So we need to include our nurses, our subspecialists, our doctors, our pharmacists, as well as parents, youth, and children. And I think they have been a lot of the drivers of the research in our program from an advocacy perspective, but also from a questions perspective. They want to see research, they want data, and they want to know that the products that they're accessing are safe for their children. This led us to the formation of the Canadian Childhood Cannabinoid Clinical Trials. We call it C4T because this acronym, it's a bit of a mouthful. And this was created in 2018 to address these exact knowledge gaps and to engage parents and youth, as well as policymakers in research. We have more than 90 members. We're actually close to 100 members now. We meet monthly. And we also have a site lead. So we have a site lead at every pediatric healthcare center. So all the big children's hospitals hospitals in Canada. Almost all of them. We're still missing a couple on the East Coast. And this is to bring physicians together. So again, physicians get asked questions and many are uncomfortable answering them because we don't have, a product monograph to tell us. How do we start a product? How do we select a product? How do we ensure there are no drug interactions? And so this really brings people who have questions to our network where we can troubleshoot together. Oftentimes there may be someone in BC who has some expertise that maybe has dealt with a similar case. And this is really because we don't have clinical trial data to guide those treatment decisions. Now, we do have several ongoing studies, including 2 clinical trials, one in chronic pain and one in symptom management and children with cancer. But we also have a lot of what we call real world studies. So we, set out to do clinical trials, but we kind of very quickly realized, where do we start? What products are people using? Where are they getting their information? How do we share knowledge with youth? And how do we engage them in research? So we have a registry that's looking at patients in neurology, in oncology as well, and trying to gather some of that data of what products are people using and what are they finding is working for them. And I think the link to our website should be on the screen here. If you're looking for more information, we do have studies also looking at research ethics, as well as policy studies. For example, we have a working group looking at medical cannabis storage, administration, and disposal in schools. So I just wanted to highlight one project, and then I'm going to open the floor to questions around engaging youth in research. And this has certainly been one of the highlights of this work. And this came about, we were meeting with some youth about a study design, and they said, we never learn about cannabis for medical reasons. We're always told, cannabis is a substance of abuse, stay away, steer clear, similar, as Dr. Balinese mentioned, to how we would discuss tobacco and alcohol. So this creates a stigma around, if we do, in a few years have some high quality evidence, how are youth going to feel about having to take a medical cannabis product at school and around their peers, and maybe integrating some education on the potential medical uses as well, alongside some of the harm reduction work as well. So this has really been a great highlight. And certainly with that, I would open the floor to any questions from the audience.
Okay, thank you. Okay, we have a few questions that I see there from the audience. So we often talk about medical cannabis in these talks. So can one of you just try and address the difference between THC and CBD, and then the health aspects that we know about THC use by the general public recreationally, and the CBD use, which people think of more as a medical thing, but the THC certainly has aspects too. So not sure who to call on for that question, but
I'm happy to start it off at least. THC, tetrahydrocannabinol, is generally recognized as one of the psychoactive members of the cannabinoid group, I guess. It has a direct effect upon receptors in the brain as well as in the nervous system, and it can cause some of these issues. So things like hallucinations, paranoia are often seen as side effects or undesirable side effects for people. However, we also know that it has some effect upon things such as nausea, and it has been used in clinical trials for patients who have chemotherapy-induced nausea. It has been used for patients who have neuropathic pain in both chronic pain scenarios, rheumatologic or inflammatory pain, as well as in cancer pain. THC has been used in studies to help out with appetite. It's also been used or has been found to be beneficial in patients who are using it for sleep issues. So it definitely has a medical purpose, or has been found to be medically useful. CBD or cannabidiol is a member of the cannabinoid family that is non-psychogenic. It does not cause any sort of hallucinations or any issues with getting high, if you'll use that term. But it too has been found to be very useful for some very specific areas, just as Dr. Kelly talked about, for epilepsy, especially childhood epilepsy syndromes, has been used for anxiety issues, post-traumatic stress disorder, and is certainly undergoing a lot of trials right now, especially in things such as anxiety, nausea, even pain issues. Those are only the two of the group. There are probably more than 110, 120 cannabinoids that can be found in any cannabis cultivar. With that, though, there often is the thought that these cannabinoids work together, not separately, to create the benefits that we see. So if we pull out THC and we use it in a clinical trial, we may get a different result than when we're using the whole plant or a whole plant extract.
And just to add on that, if I have a moment, I think, Paul, your point about separating out the cannabis, we think of cannabis plants, it's not just CBD and THC. There's a lot of other active compounds in there. And so when we see a product like Epidiolex, which is an isolated CBD only product, if you will, there are still trace amounts of THC in there. Now they do their best to sort of rid the product and have it just pure CBD, but it's actually very expensive and very difficult to extract them out and have a completely separate product. So in pediatrics, we are using what we call CBD enriched whole plant extracts. So they're at a ratio of 20:1. So we have 20 times more CBD than we do THC. And again, in pediatrics, that's obviously because we're trying to limit the exposure, but we do think that they work better when they are together.
And there's definitely beginning research looking at some of the other compounds. CBG is one that's really starting to get a lot of interest, as well as some groups looking at terpenes, which are those aromatic kind of oils that give cannabis its characteristic smell. And people are starting to get interested if they may also have either independent therapeutic effects or, again, be part of that kind of entourage effect.
I think that's also one of the research challenges is you get a product from different manufacturers and they may say the same 20:1, 20:1. They may have totally different terpene profiles, different ratios of metabolites, and that may be what's causing some of the benefits. So it's another challenge for us when we're trying to figure out, dosing for these different products.
One of the things I've found through the years is really having to educate people about the difference between medical cannabis and cannabinoids that are prescription medicines. And so we talked about, I can't remember if it was Dr. Kelly or somebody said about how this isn't a medication and that it doesn't have Health Canada approval with a drug identifier number. It's not truly a prescription. Yes, your physician or your nurse practitioner has to do a medical authorization for you to get medical cannabis through a licensed producer, but it's not truly a prescription with a drug identification number. And so it hasn't been approved by Health Canada as that. And that is why you will rarely see an insurance company cover it. You'll probably, unfortunately, never see pharmacare cover it. If you have automobile insurance from your accident or whatever, it's very difficult to get the medical cannabis covered. There are medical cannabinoids, and so that's something like a Nabilone or a Sativex. That's actually a prescription medication that you take the prescription to a pharmacy. It gets filled just like any other pharmaceutical drug. So I think it's a real, people need to be aware of that. And then there's, on the other side of all of it, is the recreationally acquired through the stores that have been legalized since October 2018, right? And that, again, is from licensed producers in Canada. And then there's the kind of last stream of what I think Dr. Belhus was talking about the illegally acquired, which is basically what we had before we had all of these legally acquired aspects. So is that, I don't know if anybody else wants to kind of comment on the difference between medical and recreational, and why would, you know, if a patient could just go to a recreational store and buy one of these, why do they go through the rigmarole of trying to see a physician to get them to sign one of these medical documents?
I can take a stab at that because we've done some research in the hemp project asking people that very question. And what patients and family members have told us is, one is they want that legitimacy that they actually are using cannabis, you know, for therapeutic purposes. For many people, for many years, having that medical cannabis card, you know, or the authorization, it helped them when they had to talk to law enforcement if they were stopped and they had cannabis on their person. It also, for many people, they want to have their physician or their nurse practitioner to engage them in conversations about cannabis, to provide care to them related to their cannabis and have that follow-up. And they don't necessarily have that if they're going just through the recreational system. I also think that there are some places, we are starting to see more insurance companies that are willing to cover it. We see the Department of Defense covering it for some individuals with PTSD in particular. And so again, having that authorization can really make a difference financially. And then lastly, for people that are, you know, perhaps their children are in school, for someone that's in a workplace, there are some workplaces in Canada that say you cannot consume cannabis on the job or in the school. And so when you have medical cannabis authorization, it then becomes a human rights issue in terms of being able to have access to your medication. And so that authorization can help people have that dialogue with HR to ensure that their human rights are being protected and they're still able to consume their medication in a way that's still safe for themselves and for people they may be interacting with in their workplace. But without that authorization, they're just considered to be using it recreationally. So I think those are a lot of the issues that underlie people wanting to keep that medical cannabis program going and being able to still have that conversation with their healthcare provider.
I liken that that where you can use it to, you know, recreational cannabis would be like pulling out a beer. You know, so if you're sitting in the park, not that we wouldn't love to have a beer in the park, but anyway, if you're sitting in the park, or if you're sitting in a restaurant, or if you're a patient in a hospital, pulling out a beer versus, so if you pull out your recreational cannabis and start using it versus your medical cannabis is if you're sitting in the park and you need to take your lunchtime pills, you can take your lunchtime medical cannabis. And so it has implications for people living in long-term care and people if they're in hospital, but like you said, at the workplace and places like that. Okay, so we heard that medical cannabis has been available in Canada to be authorized since 2001. But it seems one of our questions is, has there been a measurable shift of moving from other prescription drugs to medical marijuana in Canadians' population in the last few years? And it seems like that, like since we got the recreational approval, there's suddenly been this huge explosion, I know even in my own practice, of people asking for medical cannabis, even though it's been available for medical uses since 2001. So have you guys seen that?
Some of it relates to the acceptance and the stigma. So early 2000s, cannabis was still related to be marijuana. Marijuana is a pejorative. It was used for the illegality of cannabis. So people didn't necessarily want to be known as using pot or using marijuana, whether it be for medical purposes. The older the person was, the more stigmatized they became. So you can imagine your grandmother using cannabis to help out with her arthritis, and so she might be labeled a number of different things. I think that as Canada has gone through the process of discussing this in a very public way, legalizing it, both medical and recreational, people have been feeling more secure. They also have been looking at more of the research and learning that it's safe in many ways, especially when prescribed and being followed by a medical professional. And because of that, I think that we're seeing more people that are coming forward, either from their son or recommended by their son, grandson, the neighbor down the block, to try this, to see if it's going to make a difference. Who wants to be on, narcotics? Who wants to be on morphine for the rest of their lives because of pain? So that's another thing. The opioid crisis has forced people to look elsewhere to see if there's other medications that can help out. And we are seeing in different jurisdictions a reduction in the number of opioid or narcotic prescriptions. We're seeing a reduction in the use of benzodiazepines, the sedatives or anxiolytics that people are using. So that tells us that they probably haven't stopped using them. What they're doing is substituting. They're finding a better substance for them in order to benefit and to function.
I have to say that, and I'd be interested in all your thoughts on this. In some ways, we see almost too much of a shift. So, many of my patients are asking, well, I just want to use pot for that, for their pain, for their spasticity. And I mean, first line for spasticity, for example, is still baclofen. But many of my patients are saying, no, I don't want a synthetic medication. I don't want a pharmaceutical. I want something natural. And, and I kind of try to point out that many pharmaceuticals do come from plants. But anyway, and so there has been a huge shift, I find, sometimes not for the good. Yes, the stigma has been decreased, and yes, people are asking about it more, sometimes when it's appropriate, but sometimes they're hesitant to really follow the gold standard first-line medications for their symptom management because of that. I don't know, Dr. Danek or anybody else, if you have seen that. Oh my God.
So I will say, just while Karen is unable to chat for a second, we certainly see a lot of this in the parent communities, especially when we think about kids with chronic pain. The most recent guidelines are really that there's not enough strong evidence to recommend the use of cannabinoids in pediatrics for pain, and that it can be considered as sort of a third line when nothing else has worked, and a case-by-case basis, so not an overarching recommendation. And I think we do hear the same thing that you mentioned, Karen, that this is a natural product and we think it's safe, and especially if the parents are cannabis users themselves, they're generally very strong advocates for, I think this is safe, I don't think that there's any side effects, and I want to try this first, especially if one of the options may be something like an opioid or a benzodiazepine, of course, which come with their own risks. And certainly, I think we hear a lot from our epilepsy families that some of those medications have a lot of side effects. And so they want to be off some of the anti-epileptic medications because they just make their kids feel like garbage. And the cannabis really kind of counteracts that. And so we do see for sure a lot of increasing interest in a lot of indications.
And I think it really emphasizes the need to have these conversations, and to be honest, that we don't have all the answers yet. We may not know all the long-term risks, although, yes, we've had cannabis in our society for a long time, but in terms of its role as an actual treatment, there's a lot we don't know. Whereas some of the first-line drug treatments we have studied, we do have a better sense. So having that dialogue, I think, with patients, with parents, with family members is really important, because there's a lot of misinformation, I think, out there on the internet. They're hearing it within their social networks. A lot of it is well-meaning, but a lot of it is not backed by science. And so I think we need to have those conversations. And again, that's why I'm a real advocate for keeping that medical cannabis system separate, so that we're really pushing people to have those dialogues with their healthcare providers.
Absolutely. And I think you hit the nail on the head about the long-term risks and what we don't know. And one of the risks is that we really don't know, especially with the medical cannabis product. We're not talking about the high THC, that might be used on a Friday night to recreationally with your friends, and all of the confounding variables that go along with those observational studies. We're talking about products with very, very low amounts of THC. We're talking about high CBD products. We're talking about steady state dosing. We're not talking about, maybe 3 joints on a Friday night. And it's a very different ballgame when we're looking at risks. And that's something that our team hopes to do, and I hope other researchers do as well, is really look at the long-term effects of medical cannabis products that aren't necessarily, what you'd be seeing, not smoked inhalation as well. In pediatrics, almost no one's advice is to smoke cannabis. They're using more oil products. And of course, this is going to have a different effect. It has different effects long-term on lung health and all of those things. So I think a lot of what you said around not knowing the risks are honest discussions that we need to have.
So one of the questions from the group actually relates to that. So the long-term risk of triggering schizophrenia in the youth. So that's been a lot of the naysayers against, legalizing cannabis, whether it's medical or recreational, has been because of the risk of triggering schizophrenia in youth. So I don't know who wants to take that, whether Lauren or...
I can just speak briefly. So there was the latest evidence on that out of Cochrane, which is a group that kind of synthesizes all of the medical literature. I think is out actually last year. It's reasonably up to date. I think there's been 24 different studies, again, almost exclusively on recreational products. So again, completely not what we would be recommending for most pediatric indications. And the evidence is inconclusive. Some studies show there might be a link. There's a lot of confounding variables. And I'm pretty sure the conclusion is really we need more evidence. We can't make a decision on whether or not there may be some cause and effect there. And that more research is needed. So the latest evidence is that we're not sure.
And I think probably even the anecdotal evidence that people thought that, was based on the high THC, the recreational, yes, they're smoking THC quite heavily. And what you're talking about is more the high CBD products for medical use. Yeah.
Exactly. And we don't have any data supporting that a high CBD whole plant extract has any causal link with schizophrenia.
I definitely think if you're looking at it from a recreational perspective, that there has been that kind of harm reduction approach, saying that, we're seeing some associations in the literature that suggest that there might be an earlier onset of schizophrenia, particularly around, youth that seem to have a propensity. They may have a family member that has psychosis or schizophrenia, and that those youth seem to be at potentially a higher risk. There's been some thought, I think, that it might just cause it to happen earlier, that it would happen anyways, and not necessarily that it's causal. But as Lauren said, there's a lot more research that needs to be done. And it's hard to do. As you can imagine, we can't really do a clinical trial on recreational use of cannabis with youth and young adults. So we're really relying on good data, population-based data, which is not always easy to get.
And not always well self-reported. So that's something we really see is not, and I think this is starting to happen more and more because of recreational access, but youth aren't like, oh, yes, doctor, I'm using cannabis 7 times a week, behind the portable, if there's portables are still a thing. And we see this in pregnancy. So we look at rates of cannabis use in pregnancy, and that's really poorly self-reported, much with many substances in pregnancy, and it makes it really hard to do research when you're not really sure where the exposures are happening.
Okay, I'd like to switch gears a little and talk about nausea. So nausea, the next question is actually specifically about nausea secondary to gastritis. So we know that CBD is a bit of is an anti-inflammatory. So the question asks, does it actually promote healing of the mucous membranes? I guess, on the internet, you can find lots of proposed things on the internet. And does anybody know of actual evidence for that? Not sure if anybody in this group knows that evidence, that literature.
Well, what we do know, gastritis is a very specific issue, but if you're talking about inflammatory bowel or inflammation of the bowel in general, there has been some literature that suggests that the use of cannabinoids may be helpful. The studies, mostly out of Israel, have shown that patients who are using it may get some healing in general. They may feel better. They may have less use of other medications. These are either observational studies or very, very small intervention studies, like starting patients on cannabinoids. Do we know if it actually heals in gastritis? I think that we don't know enough about that yet. There are some excellent researchers in Canada. I'm thinking of Dr. Sharkey out of the University of Calgary, who's been looking at many facets of GI diseases, especially inflammatory bowel disease. And he has found that there are a number of things that cannabinoids do that are kind of normal GI processes, gastrointestinal processes. I haven't seen anything on healing of gastritis specifically, though.
Okay.
I can't find anything in PubMed. I just had a quick look. So it's
So there you go.
one of those things that are still a big question mark. And I think that's the fascinating thing about doing cannabis research is the world is your oyster. There's so many conditions that potentially could be affected by the endocannabinoid system because it's so predominant throughout our body that there's a lot of different health conditions that we're going to need to do research on, which is great if you're a researcher, but not so great maybe if you're a patient, and we're still trying to get to those studies.
So the endocannabinoid system is actually the next question. Specifically, how does THC and CBD affect the endocannabinoid system? And so for those of you that don't know, the endocannabinoid system is something we have in our bodies. So when we take cannabinoids or cannabis, the reason it does anything is because we have this endocannabinoid system in our body, and we have natural cannabinoids in our body that work on that. But can anybody comment? I don't know how technical we need to get, but on the question of how does THC and CBD, how do they work on that endocannabinoid system? Anybody want to take a stab on that? It's really a balance. So it's kind of, without getting really into like all the neurotransmitters and a whole bunch of other things that I don't know if anybody has kind of a...
Well, I think, acknowledging that the endocannabinoid system is a system that consists of receptors, cellular receptors, and there's 2 acknowledged cannabinoid receptors, CB1 and CB2, but we also see that there are 3 or 4, maybe even as many as a dozen others that have some cross-reactivity with our natural endocannabinoids. There also are both enzymes that break down the products, enzymes that build the products, so those are parts of what's going on there. And we know that the endocannabinoids can be active in a number of different places. So CB1 can be found mostly in the central nervous system, the brain, the spinal cord, some of the peripheral nerves. But then the CB2 is found in just about all of our organs, bones, nerves, the immune system. So it's not that the endocannabinoid system works independently. It's really tied into everything that we do. So even things like when you feel hungry, when you want a munchie, that can be kind of stimulated through the whole process of the cannabinoid system.
Right. Okay. So one of the members asked about the use of cannabis for fibromyalgia. So interestingly, years ago, one of our residents in our program, who's now the head of our section, Dr. Skrabek, actually did a research project, a randomized placebo control. You rarely hear that with cannabis products, but it was on a cannabinoid called nabilone. And we did this study in people with fibromyalgia. And, one of the reasons you don't see randomized placebo-controlled trials in cannabinoids and cannabis is because there's not a huge numbers of funding. Like to answer one question, for example, does cannabis help fibromyalgia? That study on any kind of drug would cost over $20 million. And the problem is no cannabis product is funded like that. And so to answer every single one of these questions, we would have to have $20 million at least. That's the base, the basic, to say, does cannabis help spasticity? Does it help fibromyalgia? Does it help neuropathic pain? Which type of cannabis? Inhaled oils, CBD prominent, THC prominent. And so in the case of the fibromyalgia, interestingly, just with 40 people in this study, it had such a dramatic effect, this nabilone, which is a cannabinoid, a prescription cannabinoid, that that small little study showed, compared to placebo, there was quite significant benefit in people with fibromyalgia. Now it needs to be done in much bigger studies and much longer trials, and that's what you hear at the end of every little study. But what about the actual use of cannabis, like the actual cannabis product in fibromyalgia? Does anybody have awareness of further evidence on that?
I think that there is some observational studies that have been done. I'm not sure about the Israeli scene, but I know that they've been observing everything. But I do know that in the United States, in some of the states where they have medical approval based on disease state, fibromyalgia is accepted as one of those diseases where cannabis can be used, or medical cannabis can be used. So I think given enough time, even a couple of years, we may start to see some more evidence one way or the other in terms of the use of fibromyalgia.
Yeah, there's been one crossover design RCT from Israel on fibromyalgia. It was just with 20 patients. So again, it goes back to that issue of being very, very small. They did find that almost a 1-to-1 THC to CBD did seem to decrease pain by about 30%. But the other groups, the other types of cannabis that were more focused on THC were the same as placebo. But again, with 20 patients, it's very hard. And, I think one of the biggest issues with clinical research is, if you do finally get the funding, do we even know what dose we should be using? Do we know what, THC CBD ratio we should be using? If it's from the whole plant, is there a certain varietal that we should be using? As Lauren mentioned, the terpenes. So if you finally get a chance to do your RCT, you hope that you've got it right, because if you don't have that right, then you could end up with no significant findings, but it may be because we don't have the right dose. And for me, dose finding studies, yeah, and we need to start doing dose finding studies, and we need to start doing some of that preclinical research, which we haven't really talked about yet, to really start sorting that out before we get into these RCTs. But those take a lot of money and also take a lot of time, which is so strange when the product is available, a block away from your house, which makes it very challenging.
Yeah,
that's also a reason why clinical trials often are hard to do. So, if you've got a product that's available, trying to convince someone to come into your research study and get a 50% chance of getting a fake drug, is sometimes hard to do, and they have to keep checking in, and so that is a barrier to research too. So a lot of people think, why can't you just do research studies on this? But There's a lot of barriers.
Yeah, and just a couple of points to make. One, Linda, on your dose finding point, I think this is a huge challenge. With traditional dose finding studies, we would do 3 patients, then increase the dose, give 3 patients, increase the dose, 3 more patients. But with cannabis, all of the, pediatric providers start with you always hear start low, go slow for every patient. And there's a huge variability in what dose patients respond to. Right. So there may not be, 10 milligrams that's going to work for every patient because the endocannabinoid system is going to respond differently. And I think, as you mentioned, Karen, also with the placebo, a lot of the times, we're talking about, we've chosen to study chronic daily headaches because that's where patients are already using cannabis products. So now we're asking them, please stop using the cannabis that's been working for you. Come to our study and we'll maybe give you more cannabis. And that's where sort of the appeal and a lot of the great work coming out of Israel are crossover designs. And I think, Karen, you mentioned that as well. And that's a design of a trial where everyone is going to get a cannabis product and everyone is going to get placebo. And it randomizes the order in which you get either no cannabis, a fake cannabis, or, cannabis product minus the THC or CBD or whatever is being studied. And it switches back and forth. And this way, it's the sort of design this way to encourage people to participate in the trials because everyone is going to get cannabis products. But it also means that everyone can serve as their own control. And I think that's really important because we see such variability in the response in pediatric patients to cannabinoids that your best comparator is yourself. And so I think we're going to see, and that's something we'll probably see a lot more of in the cannabis space, are these crossover trials. And of course, there's some challenges there. We know the cannabinoids love to stick around in our fatty tissues for a really long time. And so what that kind of washout period where you're crossing, we don't really have good data to suggest. A lot of the Israeli studies use 4 weeks. And it might be really hard to convince someone who's having chronic daily headaches or, severe pain or spasticity to not use a product for 4 weeks. So there's so many challenges around how we design these studies to the same quality that we would expect for a pharmaceutical agent. The lack of funding is, of course, a big barrier. Licensed producers are not pharmaceutical companies. They don't have the same kinds of research budgets to run preclinical, on a gambit of products and doses. So a lot of times that's left to sort of academic researchers to piece together. And sometimes, we may choose to study a product simply because it might be the only one with any preclinical information. Right. The only one the government will let us study. And so, as much as we'd love to answer so many questions, we really are limited by, even our little 20 patient studies cost us almost $500,000. So, there's a lot of questions and there's a lot of gaps in how we're going to get the resources to answer them.
Yeah. And one point I just want to add to that is, it's kind of the elephant in the room for most of us, trying to do clinical research, is when you're trying to use the whole plant. We've experienced some real barriers going through our federal, government, Health Canada, because they've tried to treat the plant cannabis like it is a drug, and that they're expecting all of this, pharmacological data attached to it. They want to see it standardized, which unless you've got a whole series of clones out there, it's really hard to standardize a plant that can vary across a season, vary across producers, etc. And so it's taken over a year. We've had a whole host of clinical trials funded over the last few years, and it's for many of them, it's taken them over a year to get a research license and or get a hold of product, even though ironically it is down the street, to actually get a hold of the product and be able to do the trials. And I briefly mentioned just the confusion and the difficulties of having the alcohol and tobacco industries engaged in our cannabis industry in Canada. Is it's made us very difficult, especially for people like Paul and myself that do cancer research. We're not going to be able to work with an industry that is partly owned by tobacco. We have to, so we can't have the same relationship with industry in terms of we would have perhaps with pharmaceutical industry. And so it's made our research more expensive and much more complicated.
All right, thank you. So a little shift, more clinical stuff. One of the audience members asks, are there any absolute contraindications to medical cannabis? And are there any, what other precautions, maybe not absolute contraindications, but anybody want to take a stab at that?
Probably the only absolute that I can think of is that someone who is allergic to cannabis. It's a plant. There are people who have developed antigens to it. They may have an allergic reaction. It could be a life-threatening allergic reaction. They should not receive cannabis products. They probably can use a synthetic cannabinoid because maybe some of those antigens don't exist or don't cross over. But honestly, probably all the other indications, contraindications are relative. And one needs to, when you're dealing with them clinically, is to look at each person individually and say, how will this affect you? Is there going to be no negative side effects for you? If there is, then we probably shouldn't be using it. Let's look at something else.
Yeah, and I think we're learning more and more about drug-drug interactions. There are some rare ones and some more common ones. In epilepsy, one of the common anti-epileptic medications, clobazam, does interact with some of the same drug metabolism enzymes as THC and CBD. And so certainly there are some, again, one-off sort of considerations for dosing. You may want to increase or decrease doses of certain medications. And that, again, speaks to why we really need to advocate for medical care and medical practitioner advice, or pharmacists. If patients are self-medicating, they may be unaware that some of the other medications they're taking can interact with cannabis. And that's a place where really some trained professionals can be really helpful and avoid some negative side effects.
I was expecting, Lauren, you're going to talk about the pregnancy, because there's been some concern that a lot of women that are pregnant have been using cannabis, and we're still trying to unpack the impact on them, but especially their infant as well.
And lactation. I think a lot of, I see questions all the time. Part of my other hat is around research on drug use in pregnancy. And one of the questions that commonly comes up, well, I'm not pregnant anymore, and I'm breastfeeding, but can I resume cannabis use? Yeah. And the truth is, we know cannabis transfers to breast milk. Cannabis loves fat, and milk is full of fat. We know that it sticks around in milk for a really long time, like more than 6 hours after using. It's not something like alcohol where, women are told you can have a drink, wait an hour, and then you can breastfeed because the alcohol is cleared quickly, little transfers to milk. It's the opposite with cannabis. We know that cannabis kind of concentrates in milk, and it lasts a lot longer. So there's not good studies. There's not good public health info out there. There's really, not a lot of physicians are knowledgeable about cannabis use during pregnancy or lactation. So sometimes they might say, do the benefits outweigh the risk? And I think that's where, again, we need to have discussions that the risks may not be all that well known, but they certainly theoretically could be there. And in pregnancy, the same. It's not really well self-reported, but we want that harm reduction. We want to have conversations about it. So I think it's important people, kind of learn how to approach these discussions, because if you're just, if you come at it from are you using cannabis, yes or no, you might not open that dialogue, and that's not going to stop anyone from using. There's some studies in Colorado around they did a cold call to cannabis dispensaries around questions about nausea in pregnancy, around first trimester standard pregnancy nausea. And I think like 80% of dispensaries said, oh yes, cannabis products will really help with nausea in pregnancy. And I mean, we really don't have any data to support that it will help. Theoretically, it could. It plays a role in managing nausea and other indications, but the risks of cannabis exposures in pregnancy, again, lots of confounders, lots of previous research looking at those high THC recreational use, lots of confounding and not good clinical trials. This is a place we're not going to get to do clinical trials of half the pregnant people use cannabis and half the pregnant people don't. And so it's, going to be a while before we have really clear answers.
Yeah. The other group I've always been concerned about, and it's the group that we're seeing the biggest shift in increase in cannabis use, is among 65 plus. Right. And there has been some concern in some cohort studies that individuals that have pre-existing heart disease, if they're using a high THC product, we have seen some cardiac events. And so again, having that conversation, looking at that whole person and all of their comorbid conditions, all their health conditions, is going to be really important, especially if they're thinking about using it not just medically, but perhaps also using it non-medically. We've seen a real shift since the pandemic has started. People are reporting that they're using cannabis more and more. Some are discussing using it as a replacement for alcohol, which has also gone up, unfortunately, during this pandemic. And so we need to be conscious of having those conversations for people that may be moving towards using more recreational cannabis, but aren't aware that they may be at risk of negative effects.
I think some of the other issues when we're talking about contraindications or precautions, many people say, well, I used it as a teenager and I got totally paranoid and I hated that and I'm never touching it.
Right.
Well, when you smoke pot that is, recreational, obviously high in THC when this kid was smoking it, they purposely want, what was in it was obviously high THC, and you smoke it, you get this quick high of THC in your bloodstream, and yes, people can get paranoid, and then you get this quick down. Well, when you're talking about medical uses, we often suggest people using oils or capsules that have the oils in it. And you get this very low, steady state in your bloodstream. You don't get this quick high. And then we're often, like we said before, talking about using more CBD heavy concentrations, and even the ones that people that use the THC heavy concentrations for certain things, they don't get that quick high if they're not using that smoked form, or even vaporized form. You do have to be careful because you still get that quick high. It's better as far as your lungs may go, but so that whole history of paranoia with cannabis use, I look at that as more of a precaution, and talk to patients about what they could try and do to alleviate that risk. Somebody also wanted to know, is it being used more to help treat addictions? I know Dr. Danek already talked about that a little bit, about, substitutions and, being able to get off things like opioids. So did anybody want to comment on that anymore? There's these changing laws about like amounts of opioids that you can prescribe.
Mm-hmm.
I know that when we've talked to patients, especially when I was at UBC and talking to people in the Vancouver area, that a lot of people were telling us anecdotally their personal experience that they were finding that it was reducing their use of opioids. People said that it was helping them if they were using an illicit substance, that it would help them with their withdrawal symptoms, things like nausea, vomiting, anxiety. They were using more of a CBD strain. But again, those are all personal stories, which are still valuable, but they're not the large kind of cohort studies or even clinical trials that have really helped us to know, can we actually use cannabis? People talk about it as a gateway drug into addiction, but some people have talked, could it be a gateway out of addiction as well? Yeah. I know that, at the downtown east side in Vancouver, they had a very, community-driven project where, with the opioid addiction getting so bad last year, they were actually handing out cannabis to individuals to keep them away from the unsafe drug supply, and people were using cannabis instead. And they did see a drop in overdoses during that time period before that program was closed.
Mm-hmm.
It's also very difficult to overdose on, an opioid, can suppress your brainstem and actually make you stop breathing. Mm-hmm. And so opioids are very dangerous for recreational use and addiction. Cannabinoids don't do that. They don't work at the brainstem to suppress your breathing. So in that way, cannabinoids are a much safer product to use. Somebody did also want us to talk about when we talk about long-term use of safety of cannabinoids or cannabis, what about the person that is a long-term user, recreational daily user of cannabis? What are the potential long-term outcomes of that, or do we know?
Some of that is dependent upon when you start and how much daily use you are and over what time period. So the younger you start, the more potential damage there is in terms of brain development. It's well known that we as humans develop our brains well into the 20s. It may be as much as 20 or 25 years of age. So if you start early, if you start at 13 years of age and you're smoking on a heavy smoking use over that period of time, they have noticed that people have decreased IQ measurements. They have more difficulty with cognitive cognition. They have difficulty with higher sort of level computation, that sort of thing. And then there are also other social and emotional changes that happen. Those people that use on the weekends, maybe one or two over a period of years, they haven't seen that sort of problem, mainly because these people are starting to use either in the university or older. So if they're in their 30s or 40s, the brain then has developed, it's gotten, you're past your apex, you're actually on the downward slide. So it really doesn't affect people as much that way. There are definitely, you can become inebriated or impacted with the use of a high THC cigarette. You should not be driving. We say that to all of our patients, whether they're using it recreationally or medically. High THC, if you've just used it, you should not be driving for at least 6 hours, maybe as much as 8 hours. But to look at all of these changes, all of the work has come out of looking at recreational users. And again, looking at the younger people to see those sort of physiologic changes. They're looking at older people to see if those changes are sustained over the years and the decades. I'm waiting for them to bring up all the work that's been done with people that lived through the 1960s and started using cannabis during that time, thinking of Deadheads and, Rolling Stone fans, that sort of thing. And yet we haven't seen a whole lot of information about it. Some of them have even grown into politicians. Oops, did I say that? I shouldn't have said that. But they are actually pillars. Some of them have become pillars of the community. So obviously it hasn't really affected their ability to get to where they wanted to be. But we just don't know. A lot of that stuff we don't know.
One thing that I often hear about is especially if you're smoking it as a cigarette, is there's been people saying, does it cause lung cancer? And I know that's a question that Paul gets all the time as well. And I feel very badly. There's one research team, in the US, I think, that's been trying to find that link for years. And they haven't really been able to find a clear link between smoking cannabis and lung cancer. And in fact, there's, some preclinical work at the bench level that's suggesting that cannabis may actually may play a role in actually treating cancer. But we're a long way to seeing it as an actual treatment yet. The only one that I'm aware of is that there is a slight association between seeing germ cell cancers, so testicular cancer, and I believe it's people that are using it in large amounts again, Paul,
Yep.
in terms of that link between cancer and using cannabis. If you are smoking it, there's always a bit of concern around lung health, and we have seen an association with an increased risk of bronchitis. If you have asthma, it's often you're more likely to have an attack related to it. You may have a chronic cough, but there hasn't been a lot of long-term side effects, that we've seen, and it's a product that's been used for years. So we have that kind of population-based data associated.
Thousands of years.
Thousands of years. Thank you, Karen.
Yes.
So one of, the problem is we talked about how important it is to keep the medical cannabis stream going, not just say, okay, let's just go to recreational, because there are important things with the medical cannabis, being able to talk to your physician about, all these different things, how to use it, what combination to use, what route to use, avoiding inhaled, whatever. But then you come to the case that happens frequently, that people are driven to use recreational for their medical needs because their family physician refuses to talk about it. And so one of our audience members asking about that, and it I have to say it irks me. Like this has been, medical cannabis has been available since 2001, and I mean, I think physicians have to stop saying, "I'm not talking about it. I'm not talking about it." Like it's our job to be learning about it. And if we really can't, advise our patients about it, there are people that have taken a special interest in medical cannabis. There are some medical cannabis clinics, and I think is some of the specialists, that treat people with a certain disease like cancer or a spinal cord injury like I do, it behooves us to, like, if I'm going to treat spasticity and neuropathic pain, I need to know about everything that's in that toolbox. I can't just go, no, I don't want to hear about that or talk about it. And but for those that can't get their family physician to talk about it, there are ways, there are physicians that they can access. And I don't know if the group wants to comment on that.
Yeah, maybe just one quick comment, and this came up really recently around the Canadian Pediatric Society as re-releasing their guidelines for medical cannabis use in children. And one of the recommendations is that this should only be prescribed by someone who is knowledgeable. Well, most pediatricians are absolutely not knowledgeable around cannabis use. And so we hear from families all of the time. I brought it up and they said, no way, or they even kind of mocked them, or they said, I won't even discuss it with you. And so one of the projects that we're actually undertaking is with one of our parents and one of our physicians. We're actually filming a video of how to interact with parents and how to have discussions about cannabis, equipping them with some resources to sort of make it less taboo around having these discussions. And also from a parent perspective as well, you don't go in and say, I'm using this and this is what I'm going to do. And, Joe down the street has a plant, I'm going to use it, but really going in and arming yourself with the right questions. And so it's from both sides around how to have these discussions, because I think, Karen, you hit the nail on the head that we really can't, just saying no isn't an answer, because these products are available. And if anyone wants to use cannabis, they can access cannabis. And from a harm reduction perspective, it really is to everyone's advantage to be discussing it with their medical care team. And so I think, I hope moving forward, we see a lot more training in medical school and residency and nursing and pharmacists and really all members of the healthcare team.
Dr. Danek, how many hours are presently being taught in medical school? I know you are the one that's teaching on it. So is it 1 hour now?
Yeah, we have a single hour lecture, although I have snuck it into a couple of small group sessions. So I would on the outside say that we've got about 3 hours worth of education on medical cannabis in the second year of medical school.
And what I want to point out is that I've been part of a national survey of nurse practitioners, which are also authorized to fill out the medical documentation. And they're in desperate need of education across this country. And I just want to say that we need to start educating our healthcare providers at the undergraduate level. We need to have continuing education available to them. And if it's a shameless plug, but the Canadian Consortium for the Investigation of Cannabinoids, CCIC, has just launched a national education program. It is in partnership with one of our leading pharmaceutical drug companies, Shoppers, just to be fully transparent. But that module is available and it is geared towards physicians and nurse practitioners who may not have had that education within their undergrad program, nor are able to maybe travel to a continuing education event. We really developed that module to kind of address some of the misunderstandings around cannabis and to make everyone feel a lot more comfortable. But I also think we need to empower patients and families to say that if your practitioner cannot support you in that, we have a duty and a responsibility, I believe, to refer them to someone that can have that conversation. It doesn't mean that you will get that authorization, but you'll at least be able to have a respectful, informed conversation about whether it's appropriate or not.
At least if the nurse practitioner or the family physician would help with that referral, then at least the patient doesn't feel like they're tangoing behind their doctor or nurse practitioner's back. So I think we only have a few minutes left, and this has been awesome. And there's always 17 cans of worms to open up. And so I think we've opened up more cans than we've closed. But hopefully this has been amazing. But there's a provocative thought that one of the people put out there that I wanted to ask each of you quickly. Where do you see medical cannabis in the next 10 to 15 years? And of all the things out there that people have suggested medical cannabis use for, which do you see the most promising? So I don't know, Linda, Dr. Bellies, if you want to go first.
I think we're going to have a whole raft of clinical trials that will be underway by that point. I think we're seeing, fingers crossed, we're seeing countries all around the world that are jumping on to understanding the endocannabinoid system and trying to leverage both CBD, THC, and starting to look at the other cannabinoids. So I think in 10 years, we're going to have a very rich evidence base. In terms of conditions, it's a toss-up. I'm prone to hoping that in cancer and cancer symptom management and side effects of cancer treatment, I believe that we will be seeing some, second-line treatments related to using perhaps cannabis for some really problematic symptoms. I think we already are seeing it moving into the mainstream around pediatric epilepsy. But I think we will probably see it around either where there's medications that have problematic side effects or conditions where we're really struggling to treat. So maybe some, pain syndromes that are really challenging. That's where I see it headed.
Mm-hmm.
Yeah, and maybe I can just follow up with that because, Linda, I completely agree with you around pain and around symptom management. Obviously, we have 2 funded studies in those areas right now, and we'll definitely have some small study results before the next 10 years. But I also think that we'll see a lot more comparatives between like the isolates and the whole plant extracts and hopefully some better placebo development, because obviously that's a can of worms I'll save for another day. But I do think we're going to see a lot of advancement in the actual methods. I hope to start seeing some more innovative trial methods, more N of 1 trials, more crossovers, and really just looking at, more than just THC as a compound, but looking at some of the whole plant extracts and some of the other compounds, as you mentioned, Linda. I think those are going to keep us very busy for the next decade.
I completely agree with both of you. There's so much work that's being done out there. There's so much that's been done preclinical now needs to be translated to clinical. And we're starting to see, I would say, little bits of that. Certainly, we've had a couple or 3 clinical trials, very small numbers in cancer. We've seen clinical trials in inflammatory bowel. We've seen the larger, better design trials in childhood epilepsy. So I'm expecting that over the next couple or 3 years, especially if the United States legalizes medical cannabis and supports it with the research money that we would hope to see, I think we're going to see an explosion in studies. We're going to see an explosion in where does this fit in our whole armamentarium for a number of different diseases.
Right. And, speaking of what studies are there, both preclinical and clinical, I think a few of you have mentioned, and some of you are on the board and stuff, of the Canadian Consortium for the Investigation of Cannabinoids. So it's CCIC, and then it's .net. So basically any study that has been done on cannabinoids is on there, but it's also where they have that educational platform that Dr. Danek was talking about. So it's a really good educational venue for healthcare professionals. The other thing is on the Health Canada website, there's also, I don't know how often it's updated, but there is some information on how to help your patient with medical cannabis and and some of the results of the trials on there too. So I think we're almost out of time. Am I right? Oh, there's the cat to say it's time.
Nora has to say hello.
So I've learned a lot from my colleagues here, and I hope everybody else has learned a lot. In closing, I'd like to thank all of you, all of the people attending and the people that put in the great provocative questions. And I'd like to thank our panel for engaging in tonight's discussion. I hope everybody found it informative and got as much out of it as I did. We encourage you to tune in again for U of M's next season. So it'll begin in early fall 2021. And for details on that lineup, check out the umanitoba.ca and then / do we have that website to throw up or no? Café Scientifique website in August. And the plan is to continue for now in an online format, but you know, get your vaccines and maybe we'll be able to open up soon. So I'd like to thank everybody and have a great night.
Thanks,
Thanks,
Karen.
everyone. Take care. Be well.